Diagnosis of diabetes. So diabetes mellitus, you look at the clinical symptoms, and clinical symptoms are related to hyperglycemia. Polyuria, increased urine output. Why would we produce more urine? Well, we're going to have a lot more glucose in the blood, and that glucose is excess, and it usually spills out into the urine. Now, the proximal tubule of the nephron system is supposed to reabsorb or suck back in the majority of the glucose. There should be zero glucose spilling over in the urine. But if there is a lot of glucose in the blood to begin with, if there's hyperglycemia, what happens is that proximal tubule can't possibly reabsorb all of it. It reabsorbs down its concentration gradient, which means it's still a lot of glucose is going to be left in the urine. So if you have a lot of glucose in the urine, water is also going to want to be in the urine, and that's because it's going to want to go down its concentration gradient. So through the process of osmosis, you're going to have the water kind of follow the glucose. So if you have a lot of glucose in the urine, the water is going to also go into the urine to dilute out that glucose so that everything has an equal concentration on both sides of the membrane. And that's what polyuria can be caused by. So lots of glucose in the urine means also lots of water will accompany that, and that leads to excess urine production. Polydipsia, well, you're losing a lot of water in your urine, so of course you're going to be thirsty. So increased thirst. And polyphagia, increased appetite. Other symptoms include weight loss, increase in bacterial or yeast infections. Bacteria and yeast love to eat sugar. So if there's lots of sugar all over your body and in your tissues, sometimes like in women, that glucose can deposit in the tissues of the vagina, and that can cause an overgrowth of yeast in the vagina. Sometimes it can coat the inside of the mouth, and that can cause an increased incidence of oral thrush or yeast in the mouth. So as I mentioned, bacteria and yeast love to eat sugar, and if you've got a lot of extra sugar in the body, that's what they're going to want to eat. Fatigue, blurred vision, frequent vaginal infections, or the cessation of menstruation, so your menstrual cycle stops, or impotence. The diagnostic criteria, according to the ADA, symptoms of diabetes plus glucose greater than 200 mg per deciliter, or a fasting plasma glucose greater than 126 mg per deciliter, or 2-hour post-load glucose of greater than 200 mg per deciliter during an oral glucose tolerance test. The glucose load equivalent of 75 grams of anhydrous glucose dissolved in water. It's not recommended for routine clinical use. So this is a table of the diagnosis. Normal fasting glucose below 6.1 millimoles per liter, or if we look at mgs per deciliter, which is what more commonly you're going to see on a qualifying exam or an exam for this class, below 110. If it's 110 to 126, you have impaired fasting glucose, or plasma glucose 2 hours after a 75-gram load, 140 or above but below 200, impaired glucose tolerance. So that's diagnosed during the oral glucose tolerance test. And then we look at the criterion, random plasma glucose. So if at any moment in your day it's 200 or above, it's diagnostic. If you fast and you have a fasting plasma glucose 126 or above, then that's diagnostic, or 2 hours value after an oral glucose tolerance test of 200 or above. So laboratory tests, the measurement of blood glucose, diagnosis of diabetes on the presence of elevated blood glucose, and clinical symptoms. Routine screening is done of those greater than 45 years, and that's now recommended by the ADA. Tests to monitor diabetic patients, glycated hemoglobin. It's detection of microalbuminuria, so small amounts of albumin in the urea. Monitoring of nephropathy. Detection of acute crisis situations, so hypoglycemia, ketoacidosis, lactic acidosis, hyperglycemia, hyperosmolar, non-ketotic coma. So fasting plasma glucose levels of greater than 126 mg per deciliter is highly suggestive of diabetes mellitus. 110 to 126 is borderline. Impaired fasting glucose, the metabolic stage between healthy and diabetes. It's directly proportional to the severity of disease. Levels greater than 126 mg per deciliter coincide with increase in incidence in retinopathy, nephropathy, and fatal coronary heart disease. Glucosuria may be observed with levels greater than 180 mg per deciliter. Ketoacidosis can occur with levels greater than 140 mg per deciliter. There's wide swings in plasma glucose levels, even in the controlled diabetic, that can contribute to complications of disease management of insulin levels, and that's critical. So then you can take a look at this. As I mentioned previously, we typically go with the mgs per deciliter on our test questions, so that's what you should be aware of. Below 55 mgs per deciliter is considered hypoglycemia. However, if you remember from the previous lecture slides, then it would have to be below 50 before you'd actually have neurological symptoms of that. Typically, hypoglycemia goes largely undiagnosed, it's largely asymptomatic, and it is pretty rare to actually have something happen with hypoglycemia unless there's like an overdose of insulin or something like that. Glucose determination. Important to the differentiation of hyper from hypoglycemia in diabetic patients. So sample considerations, blood versus plasma. Fasting whole blood glucose is 12 to 15% lower than plasma glucose. Capillary versus venous blood. During fasting, capillary blood glucose is 2 to 5 mg per deciliter higher than venous blood. With glucose load, capillary blood glucose is 20 to 70 mg per deciliter higher than concurrently drawn venous samples. So knowing where the blood is being drawn from is going to be important. Avoid hemolysis. This is important. So hemolysis is breaking open the red blood cells. If there's hemolysis and you had glucose that was inside of your cells, so not a lot of glucose would be inside of your red blood cells, but inside your white blood cells, because your white blood cells are doing, their cellular respiration, they're using that glucose for energy production. If you're breaking apart your red blood cells, you're probably also breaking apart your white blood cells, and that can lead to falsely elevated glucose levels. Avoid glycolysis, because glycolysis decreases serum glucose 5 to 7%, or 5 to 10 mg per deciliter per hour in normal uncentrifuged blood. Higher with leukocytosis or bacterial contamination. Glucose concentration is stable in non-hemolyzed, sterile, and separated serum. 8 hours at 25 degrees Celsius or 72 hours at 4 degrees Celsius. Separated plasma contains leukocytes. So it's best to let the blood clot, then centrifuge it, and then separate the serum from the rest of the clotted cells, because then you have pure serum and it's most stable. If you have cells that are still active and in that sample and mixing with the plasma or the serum or whatever you allow or whatever you've collected that sample with, then you're going to have those cells do their metabolic processes, and they're going to still undergo cellular respiration just as if they were in your body. So they're going to be consuming glucose. So that could lead to falsely decreased levels of glucose in the blood, because they're going to be pumping that in and decreasing your blood glucose. Inhibited by the addition of sodium iodoacetate or sodium fluoride in the specimen, and that's stable for 3 days at room temperature. Sodium fluoride is a weak anticoagulant. Sodium fluoride or potassium oxalate. Addition interferes with other assays. Fluoride inhibits urease and other enzymes. Potassium oxalate causes a loss of cell water, diluting the plasma. It does not affect the rate of glycolysis in the first hour. It's typically not necessary if the samples are analyzed within 60 minutes. The exception is in cases of leukocytosis. Differences of up to 65 mg per deciliter are observed between samples with and without inhibitors after 1 to 2 hours of contact with blood cells. CSF and urine glucose. Cerebral spinal fluid may be contaminated with cells or bacteria. It needs to be analyzed immediately, centrifuged and stored at 4 degrees or minus 20 degrees Celsius. Urine is not a good marker for diabetes. Normal renal threshold 180 mg per deciliter, increased in diabetics 300 mg per deciliter. Large dilution is typically required. Preserve with an addition of 5 mL glacial acetic acid to inhibit the bacteria. Other proposed preservatives may not be satisfactory, so sodium benzoate, chlorhexamide, sodium nitrate, benzthonium chloride, stored at 4 degrees Celsius during collection. As much as 40% glucose is lost after 24 hours at room temperature. So the Benedict's method of determining glucose. Benedict's method detects total reducing sugars, and it's based on the reduction of copper. Cu2 plus, or copper 2, plus glucose yields copper 2 oxide plus copper hydroxide. It's used as a urine screening test for newborns and the detection of inborn errors of metabolism. Differentiate glucose from the presence of other reducing sugars suggested by positive urine but negative blood by enzymatic assays. The Benedict's method is a spectrophotometric assay, so that once it's reduced, it produces either a red or a yellow color, so it changes color, and that can be detected by a spectrophotometer. Enzymatic assays, hexokinase method. So glucose plus ATP, hexokinase, yields glucose 6-phosphate plus ADP, glucose 6-phosphate plus NADP, glucose 6-phosphate dehydrogenase to produce 6-phosphogluconate plus NADPH plus hydrogen. Measure at 340 nanometer absorption. So again, this is another spectrophotometer reading. NADP is used as a cofactor if hexokinase is derived from yeast. NAD is used as a cofactor if hexokinase is derived from bacteria. It can be used to measure glucose in the blood, urine, serum, CSF. And this is the basis of the reference method, typically corrected for interfering substances with reagent blank. Hemolysis, drugs, bilirubin, lipemia are all issues that are associated with those interfering substances. Glucose oxidase method, you can see the reaction above, glucose plus oxygen, you add glucose oxidase, which produces gluconic acid and hydrogen peroxide. Hydrogen peroxide plus a reducing dye, and you add horseradish peroxidase, releases an oxidized dye, which has a color to it, plus water. And that's suitable for urine or dipstick testing, blood, serum, CSF. It's quantitative with serum using a variety of indicator dyes, and it's semi-quantitative or quantitative with urine dipstick method. Glucose oxidase is highly specific for beta-D-glucose. 36% of glucose in a sample is the alpha stereoisomer. Extended incubation times will allow spontaneous conversion up to the beta stereoisomer. Addition of mutarotaase will accelerate the reaction. Coupled peroxidase method is nonspecific and accounts for interferences in the assay. Uric acid, ascorbic acid, bilirubin, hemoglobin, tetracycline, glutathione inhibit in the reaction. Ascorbic acid interference particularly noticeable in CSF. When glucose is low, ascorbic acid is high. Catalase contamination in reagents acts to decompose peroxide, and that inhibits the reaction. Alternative detection is listed here. This isn't very common and cannot be used for the detection of glucose in whole blood, but it's not susceptible to those interferences that are noted in the peroxidase coupled reaction. Glucose dehydrogenase method. Glucose plus NADH. You add GDH to produce D-gluconolactone plus NADH plus H+. Mutarotaase is added to convert alpha glucose to beta glucose to decrease the reaction time. It's highly specific for glucose. Not susceptible to interferences from anticoagulants or other interfering substances commonly found in serum, and it's also suitable for CSF. It agrees well with the hexokinase method. Despite these advantages, it's not commonly used in the United States. Functional glucose determination, so postprandial plasma glucose, it's the measurement of the clearance of a glucose load, typically following consumption of 75 grams of glucose in a drink. A sample is drawn 2 hours after consumption of the drink or meal. Glucose levels greater than 200 mg per deciliter at 2 hours are indicative of diabetes. 2 consecutive tests are recommended for diagnosis. It's widely used but highly inaccurate. Variables include age, weight, previous diet, activity, illness, medications, time of day, actual size of the glucose dose. When the meal is used as a loading dose, results depend on digestion and absorption of disaccharides and polysaccharides. Oral glucose tolerance test. It evaluates the glucose clearance under defined controlled conditions. Standardized by the Committee on Statistics of the American Diabetes Association. It's not recommended for standard use, but may be necessary in the following conditions: diagnosis of gestational diabetes, diagnosis of impaired glucose tolerance, evaluation of unexplained nephropathy, neuropathy, or retinopathy with random glucose that's less than 140 mg per deciliter, population studies, or borderline fasting glucose levels. Oral glucose tolerance testing, the standard conditions: minimum carbohydrate intake of 150 mg per day for 3 days prior. Intake less than this lowers the intolerance. 8 to 16 hours fast prior to the testing. Patient must be ambulatory, meaning must be able to walk around. Inactivity decreases tolerance. Exercise and emotional stress should be avoided. Factors that affect the oral glucose tolerance test: illness reduces tolerance, hormone abnormalities, thyroxine, growth hormone, cortisol, catecholamines, like epinephrine, drugs, oral contraceptives, salicylates, nicotinic acid, diuretics, including caffeine, hypoglycemic agents, insulin, sulfonylureas. Time affects results, so conduct the test between 7 a.m. and noon. Evaluation should be adjusted for age. Glucose load should contain glucose only, no dye or polysaccharides. Load size, 40 grams glucose per meter squared body area. Typically 75 grams of glucose, total glucose is necessary. So the interpretation: if it's greater than 200 milligrams per deciliter at 2 hours, that is suggestive of diabetes mellitus. So this has kind of been repeated throughout, and now you can see the curve of what would be normal versus abnormal. So measurement of blood glucose aids in the diagnosis of diabetes based on the presence of elevated blood glucose. Routine screening is now recommended, as I mentioned, but when you want to monitor diabetic patients, you look at glycated hemoglobin, HbA1c, or the detection of microalbuminuria. Glycation, so the non-enzymatic addition of a sugar residue to the amino acid group of a protein. Glycated hemoglobin has 3 fractions: HbA1a, HbA1b, HbA1c, also referred to as fast hemoglobins. Glycohemoglobins, glycosylated hemoglobin, or glucosylated hemoglobin. HbA1c is the predominant fraction, about 80% of HbA1, and it's formed by the irreversible condensation of glucose with the N-terminal valine residue of each beta chain of hemoglobin. So here you can see the steps involved with the formation of hemoglobin, or HbA1c. So step 1, glucose reversibly binds to the accessible amino groups. Step 2, aldimine undergoes irreversible rearrangement to form ketoamine, and then you have the formation of the glucose ring structure. The significance: this represents the integrated glucose values for the preceding 6 to 8 weeks, free of day-to-day variation. So you can measure someone's blood glucose levels every day at the same time, different circumstances, different dietary conditions, and all those values are going to vary. but we can look at HbA1c as the estimate of what's been going on for the past 6 to 8 weeks. It's not affected by exercise or recent food ingestion. High levels are indicative of poor control of the diabetes, correlate with future complications, especially retinopathy. So interpretation, 7% means poor control of diabetes, 6% means good control of diabetes, and 4% or 6, anything between 4 to 6% is the reference range. Falsely low levels of HbA1c are found in hemolytic anemia or recent significant blood loss. Falsely high would be found in iron deficiency anemia, carbamylated hemoglobin attachment of urea formed with renal failure, acetylated hemoglobin, pre-HbA1c, or variant hemoglobin. How we determine HbA1c? Separation based on charge differences, so ion exchange chromatography, HPLC, electrophoresis, or isoelectric focusing. There are structural differences, so affinity chromatography or immunoassay can detect those structural differences. Chemical analysis, photometry or spectrophotometry. Results are expressed as a percentage of total hemoglobin. Here you can see hemoglobin electrophoresis. And then we would use a densitometer to determine the density of the area, and we can do calculations to figure out the relative percentage. Ion exchange chromatography. Column is packed with negatively charged resin. Red blood cells are lysed and loaded into the column, and hemoglobin is positively charged and interacts with that column. Eluted with buffer with ionic strength adjusted so that glycated hemoglobin is eluted first. HbA1a, B, and C, collectively HbA1, is measured spectrophotometrically. Remaining hemoglobin is eluted with a second buffer, determined spectrophotometrically, and then you calculate the percent, the HbA1 divided by the total. Ion exchange chromatography. There are some analytical concerns. So pre-HbA1c will elute with stable ketoamine, falsely elevated results. Destroy by pre-incubation of red blood cells with saline, or in buffer pH 5 to 6, or dialysis or ultrafiltration of hemolysolates. HbF co-elutes with HbA1, attachment of non-carbohydrate moieties to hemoglobin, which can be seen in uremia, alcoholism, lead poisoning, chronic aspirin treatment. It will elute with HbA1. Other hemoglobin variants retained on the column, HbS and HbC, decrease the relative concentration of HbA and falsely decreased HbA1.